Hello, and welcome to the CHEST Journal Podcast, where each month we host a discussion with the authors of important articles from the current issue of the journal, adding context and commentary to the challenges facing clinicians in the fields of pulmonary, critical care, and sleep medicine. To introduce today's topic, here's your host, Dr. Alice Gallo Moraes.
Hi, everyone, and welcome to CHEST Journal Podcast. I am Alice Gallo, an intensivist at Mayo Clinic, and today I have the pleasure of talking to Dr. Nathan Nowalk and Dr. Babak Mokhlesi, and we're going to talk about their work on gender differences in outcomes of ambulatory and hospitalized patients with obesity hypoventilation syndrome. Welcome. I was hoping that Dr. Babak and Dr. Nathan Nowalk could introduce themselves and tell our listeners about what in your day-to-day work inspired you to do this investigation.
Sure. This is Babak Mokhlesi. Thanks for the invitation. It's an honor. I am a pulmonary critical care and sleep physician. I've been in Chicago now for 30 years for residency, fellowship, and as a faculty. And 3 years ago, I moved to Rush University Medical Center in Chicago as division chief of the pulmonary critical care and sleep division. And early in my career, after I finished my fellowship at Northwestern, I was a faculty member at our safety net hospital here in Chicago, Cook County Hospital, which is now called Stroger Hospital. And during those 5 years that I was there as faculty, we had a lot of patients with obesity hypoventilation syndrome, patients with severe obesity. Many of these patients were minorities patients who had, in terms of socioeconomic status, disadvantaged population. And that really sparked an interest in me because, and I'm dating myself here, this is in the early 2000s, 2001, 2002, there was not that much literature in terms of guiding us how to care for these patients. So my colleagues and I back then, this is now more than 20 years ago, started actually collecting data, garden variety, Excel spreadsheet, collecting data on our patients, day-to-day practice to kind of put together some data and do some analyses in terms of what's the best way of recognizing these patients, what's the best way of treating them, what's the prevalence in our practice. And that's how really I got interested in the field of obesity hypoventilation syndrome. I think it's a particularly interesting condition because it's one of those diseases that impacts the spectrum of our practice. We see them as an outpatient in pulmonary clinic or in sleep clinics. We see them on the pulmonary consult service in the inpatient setting. And of course, we see them in the intensive care unit when we decompensate.
Yeah. Dr. Nathan Nowalk, do you mind introducing yourself to our listeners and tell us what inspired you to join Dr. Mokhlesi in this work?
Absolutely. Yeah. So my name is Dr. Nathan Nowalk. I am a pulmonary critical care and sleep physician, but currently still in training as a research fellow, supported by a T32 training grant at the University of Chicago. I would say what brought me to this topic, and honestly what brought me to sleep medicine, was, the obesity hypoventilation syndrome patients you see who are critically ill, and just kind of being so concerned that they could have potentially avoided these episodes of critical illness had they received, outpatient care, such as PAP therapy or weight loss. And it was kind of striking to me actually with Dr. Mokhlesi in the ICU in my first month as a fellow at University of Chicago, seeing these patients with such severe illness that potentially could have been preventable, and also a condition that we know very little about as time has gone on. As Dr. Mokhlesi said, those were the earliest descriptions of it. So it's still, many unknowns in this area as well to be learned about.
I love that. I love and appreciate and want to appreciate that both of you were inspired by the patients that you have been caring for. So I really appreciate that. So share with our listeners a little bit about the background of your study and why specifically you wanted to look into gender disparities.
Sure, I can start on how we got interested in this, and it was somewhat serendipitous, if you will. Back in 2016, I was tasked by the American Thoracic Society to lead the development of a clinical practice guidelines for obesity hypoventilation syndrome. And in that process, of course, we have a lot of colleagues from various regions of the world. And one of the questions that we wanted to address was, what is the best strategy of dealing with patients who are hospitalized with obesity hypoventilation syndrome? And because I think a lot of clinicians cared about that question, both hospitalists, pulmonologists, intensivists. And since there was a paucity of data in the literature, what we ended up doing with ATS's support was to reach out to investigators who had published their work and try to gather the subgroup of their patients who were actually hospitalized within their entire cohort. And we reached out to multiple investigators, gathered data, and were able to develop a meta-analysis at the individual patient level meta-analysis for the ATS. And that got published and all went fine. Later, and at that point, it never occurred to me to look at gender differences, to be honest with you. And, at some point later on, a few years later, I started looking at that and it's embarrassing, but I should have done it earlier. But, and I noticed that there seemed to be some discrepancies in terms of men and women with obesity hypoventilation syndrome in that data set. And that's kind of what inspired me to ask colleagues like Nathan and others to start looking at other data sets out there. And maybe I'll let Nathan take on from here.
Best time is now. Just wanted to make sure that we say that out loud.
Yeah, absolutely. It's definitely an area of obesity hypoventilation and other, chronic lung conditions or sleep conditions that we need to look at in terms of all of these studies that have been done before is, was there any concern for gender difference? And is that gender difference explained by biologic or social mechanisms? And, in this particular, work, we wanted to look at outcomes specifically. And so that I think was always driven by Dr. Mokhlesi's work in, looking at the outcomes of obesity hypoventilation syndrome patients in general. But this idea that, sleep apnea is more prevalent in males is pretty well established at like a 2-to-1 male to female ratio. But strikingly in obesity hypoventilation syndrome in females is much more common, or I should say more equal between the genders. And so, you see different cohorts across the world and not just in the United States, but like, in Saudi Arabia, there was a cohort of ambulatory patients where it was actually 2/3 of patients presenting to the clinic. This is an ambulatory sleep clinic, had, female gender, or excuse me, they were women, of 67%. And then in regards to, hospitalized patients, you see patients in Spain, France, and the USA, 60 to 70% of those presenting with acute on chronic hypercapnic respiratory failure are women more than men. And so I think that is kind of the early concerns we had about these gender differences in both presentation and the severity of their illness. And we wanted to know if this played out in their clinical outcomes as well.
Yeah, I was very surprised about what you were saying, that several cohorts throughout the world found that it was more women. It caught my attention when I was reading your paper. So I'm glad you looked into it. So share with us about your design and methods for your study. And I am particularly curious about why did you decide to include like both cohorts in this one study that you did?
Yeah, I think we wanted to take advantage of, first, the reason we wanted to combine both was because we thought it would make a bigger impact in terms of the findings. Certainly created some challenges because now you have to use different methods for analysis and description. So it created some challenges for putting together the manuscript. But I think at the end of the day, it was nice to be able to contrast and compare and contrast ambulatory and hospitalized patients. And the way we went about it is that we used a cohort that we put together with ATS's support for the clinical practice guidelines. We had that cohort already available to us. And then, I've worked closely with my colleagues in Spain as part of the Pickwick trials. And we thought that's it was an RCT, but there was available data on 300 patients who had been randomized in that clinical trial on which we had prospective data available. So we thought it would be a unique opportunity to combine these two cohorts to just provide a better perspective for those of us who are interested in the field in this condition.
I love it.
I would agree with what Dr. Mokhlesi said, that these are very complementary, they are very different though, and that those differences need to be pointed out as one interprets the results and, explores the individual findings, because it is commenting on two separate types of groups. One's perspective, one is retrospective, for instance, and one is an international group, one is a largely Spanish population. So you have to definitely be very aware of inclusion-exclusion criteria in both cases, and then the limitations of the data that we're, reporting on. But I do agree with what Dr. Mokhlesi said, that this gives us now, as he said earlier, a whole understanding of the spectrum of this question of gender differences in between women and men in OHS, because you're following them from the clinic into the critical care and back.
Yeah. And I loved also that some interventions proposed in one of the cohort were different than the other one, and inpatient and outpatient. I thought it was amazing. And so with that segue, let's talk a little bit about your results. So tell us what you found.
So our study had very significant findings that showed difference between women and men on unadjusted analyses, and that was true of both cohorts. Women on, generally speaking, were presenting older, about 8 to 11 years older than men. They had significantly more comorbidities, and they had worse outcomes in both cohorts as well. However, when you look at both cohorts, you found that a lot of these differences in terms of these outcomes actually started to go away as you started controlling for very important covariates, specifically age. When we looked at our ambulatory cohort, that prospective, randomized controlled trial group from the Pickwick trial, we found that, the inclusion of age, BMI, positive airway pressure adherence, and then the severity of their sleep apnea, as well as comorbidities such as like diabetes, hypertension, smoking, that this, led to a loss in the finding that there was increased risk of exacerbations in that cohort between women and men. Again, when you looked at the logistic regression modeling of the hospitalized cohort, and this is again looking at discharge outcomes such as 12-year mortality following discharge, we found that women were less likely to leave with PAP therapy and more likely to die. However, when you control again for their age and for their PAP on discharge and their hypercapnia, which is a marker of the severity of their obesity hypoventilation syndrome, you found that they actually had similar outcomes when you modeled these out. And so it does bring up some very interesting ideas about why that might be the case, that these differences kind of go away when you start looking at these different important covariates.
Yeah. Dr. Mokhlesi, anything else?
Yeah, no, that was an excellent summary. What I would add is that what was really surprising is that, as Dr. Nowalk mentioned, women were on average in both cohorts almost like 10 years older, a little bit more obese, and also, a little bit higher levels of a little bit worse hypercapnia, particularly in the hospitalized cohort. And yet, these patients, women, tend to have less severe obstructive sleep apnea, because we know that patients with obesity hypoventilation syndrome, the majority of them also have concomitant obstructive sleep apnea. And that's important because many times these patients get treated, we had previously published that, there's no difference between CPAP and NIV when you treat ambulatory patients with OHS, particularly if they have concomitant severe obstructive sleep apnea. However, in the hospitalized cohort, which tend to be majority women, these individuals, these women have substantially less severe obstructive sleep apnea compared to men. And that's, I think, has important clinical implications because when it comes time to discharging these patients from the hospital after an acute event, it stands to reason that it's best not to just prescribe them empiric CPAP while they're waiting for an outpatient sleep study, but maybe they should be discharged on non-invasive ventilation, which is not easy to get access to in the United States due to insurance problems and other issues that can come up.
And also hard to get it done in the hospital, right?
Yeah, for sure.
I was very surprised with your findings, with those findings that you mentioned as well. But I was also super surprised, honestly, with despite men having a little bit more severe in terms of AHI indexes, they could walk. They had a longer baseline 6-minute walk. They could walk longer. And they had less diabetes despite being having more risk factors for metabolic syndrome on one of your cohorts. So I was surprised about that too.
Yeah, it's interesting, but I think a lot of that is driven by the fact that women were on average 10 years older and more obese. So that was really the big driving factor. Yes. And I mean, to some extent, it's not surprising that women could have worse outcome because if you're 10 years older, I suppose you have more risk. And that's why with some adjustment for age, some of these things went away. But the reality remains that many of the patients we take care of, hospitalized patients that we take care of in the intensive care unit or on the general medicine floors, who have obesity hypoventilation syndrome are women, don't have very severe sleep apnea, tend to be older, and they tend to have worse outcomes, because at an individual level, you don't adjust for age. You just take care of patients, right?
Absolutely. And so in this segue, let's jump into talking about some of these points. Let's talk about your conclusions and discussion. I was hoping you both could talk to me about also the hormonal hypothesis that you had that I thought it was so well described and explained on your paper. So listeners, please read the paper. But let's talk about what you think is driving your findings.
So I appreciate that we really started off with a concern for gender bias in our paper. That's when we start describing explanations for these findings. We start with, as some of the things Dr. Mokhlesi was just alluding to, which is, is there a concern for gender bias where women are being undertreated or underdiagnosed? And I think that's something we acknowledge very upfront and early in our discussion section. And I think that that's a clear takeaway of this. And hopefully this paper will, continue to decrease any kind of gender gap in this particular condition or others. But some other explanations, as you just alluded to, hormonal explanations, which have been well described in the literature, are things like leptin resistance, as well as the effects of progesterone. So we know that leptin stimulates the respiratory drive and may also protect against airway collapsibility. But what we also know is that for any given level of obesity, the serum leptin levels are nearly twice as high in women. And so, there is concern that they have such high levels of leptin in these morbidly obese women that they start to develop a resistance to the, role of the hormone in stimulating the respiratory drive. And that would be a clear mechanism for hypercapnia in that regard. We also know that the hormone progesterone acts as a respiratory stimulant, and it also dilates the upper airway muscles. It's even been used as a therapeutic in patients with OSA and OHS, and I should say as a experimental or therapeutic for underexploration, the hormone progesterone. And we feel that, women who have their loss of progesterone in their menopausal years and become postmenopausal, that might pose them at risk for developing hypercapnia or at least obstructive sleep apnea, which of course would then lead to possibly OHS. And that might explain some of their later presentation in life with this condition, because they are presenting effectively menopausal, although we did not ask about, and both cohorts did not have menopausal data. So this is very much a theoretical discussion-based conversation we're now having right now. But we did report a much older female cohort. Average age in our females was 68, for instance, in the randomized control trial.
Yeah. Dr. Mokhlesi, anything else to add?
Nothing specific. I mean, one of the shortcomings of this study was that we didn't have data on menopausal status. So it's hard to assess with certainty how much is this driven by hormones. I think, as Dr. Nowalk said, one of my concerns was that women, despite having worse presentation in the hospitalized setting, in terms of having higher CO2 levels, being older, and having more comorbidities, one would think under those scenarios, there would be prescribed higher rates of non-invasive ventilation, but strikingly, they were prescribed less. So I think, it really brings it full circle that we as clinicians also need to think about why would that be. And I think my theory, and again, I have really no way of proving this 100%, but one idea is that many times as clinicians, we're wired to think about, okay, you're obese, you have obstructive sleep apnea, you have to have loud snoring, witness apnea is a typical phenotype that might be more prevalent in men compared to women. So I think we may also have a problem in accurately recognizing women as having this condition and not prescribing appropriate therapy in a timely fashion.
Yeah. Yeah, absolutely. What I personally took from your study as a primarily intensivist is that I am going to think way more and earlier about organizing to make sure that these patients go home with a non-invasive ventilation. And also, I was made aware, which I was not aware before, again, like that women present later in life. So again, as an intensivist, I think it's important to know this. But I was hoping that both of you could share one or two messages or one or two clinical points that you hope our listeners take with them to change their practice.
One take-home message from me, and the way I've kind of tried to change my practice, is understanding that women who get hospitalized with acute on chronic hypercapnic respiratory failure due to either confirmed or suspected obesity hypoventilation syndrome have really poor outcomes. And, within the next few years, their mortality is pretty high, arguably higher than many malignancies out there. Yeah. So I think as clinicians, if we recognize that, then we will become more proactive in ensuring that they get adequate follow-up, adequate treatment upon discharge. And many times, as you alluded to, sometimes giving the right treatment to the right patient at the right time in form of non-invasive ventilation. With the current system that we have in the United States, we have to jump through a lot of hoops to do that. But my hope is that with this data and future data that becomes available, that there will be less restrictions on how we can prescribe the right treatment in form of NIV for the right patient at the right time, so we can take better care of our patients.
I love that. How about you, Dr. Nowalk?
Yeah, I mean, I would certainly agree with what Dr. Mokhlesi said in terms of, how this study should definitely encourage treatment. And I think you had said that to yourself. I think going back to some of the gender gap issues we acknowledge, when I Google search what is obesity hypoventilation syndrome and look at pictures, you're often going to see the patient Dr. Mokhlesi just described, which is a male who is coming to clinic obese and snoring and these kinds of things. And I think that the more we can do to acknowledge that this is actually a very female condition amongst women, and actually which probably supports higher mortality amongst them as well. Even though we showed an adjustment, it may not be totally there. I think that we have to acknowledge these differences, and that clinicians need to continue thinking about patients with OSA, but also especially OHS, being both in men and women, and the importance of knowing about that gender disparity.
Yeah, absolutely. And what is next for your research team? Like, what can we expect to hear next from your team?
Great question. Dr. Nowalk and I have actually yesterday we were talking about this. One area that I think will be critically important to explore in this patient population is the role of weight loss. More often than not, we as sleep docs focus on PAP therapy, be it CPAP or NIV, and we don't address the main issue, which is obesity. And of course, it's not easy to address obesity. It's always a challenge, but newer medications like the incretin-based, GLP-1 and GIP-1 receptor agonists, it could potentially change the landscape of treatment for these patients. But I always caution our community, this sleep and pulmonary critical care community, that we need specific data on patients with obesity hypoventilation as it pertains to these medications for weight loss, and not simply extrapolating data from the OSA, obstructive sleep apnea studies, to patients with OHS. So I think that would be an exciting area to explore down the road in this field.
That's fun.
Yeah, I completely agree, especially in that last point that we can't just take the OSA data and apply it to OHS, because if anything, our study shows that, again, that 2 to 1 male to female predominance was not reflected in our cohort. There are far more women in our cohorts. And so you can't just, copy and paste the treatment of OSA or, modalities for, fixing that condition onto the OHS. And there needs to be dedicated OHS studies, and they need to balance genders as another thing we need to really focus on as we perform these trials.
That's awesome. I'm excited to interview you guys again. Thank you so much for joining me today. To our listeners, I, again, am Alice Gallo, intensivist at Mayo Clinic, and I had a fantastic conversation with Dr. Babak Mokhlesi and Dr. Nathan Nowalk about their study on gender differences in outcomes of ambulatory and hospitalized patients with obesity hypoventilation syndrome. Thank you so much for listening, and on behalf of the CHEST Journal, thank you, Dr. Mokhlesi and Dr. Nowalk, for joining me today.
It was a pleasure. Thank you for having us.
Yep. Thank you for having us and highlighting our work.